All right, let's get the afternoon off to a rolling start. My name is Dr. Gus Gerasi. Part of my job here, along with a team of other people here at the Medical Society, was to go out and find shining examples of physician leadership and good stuff. And when I heard about Dr. Kressly, who not only runs a small pediatric practice near Philadelphia, but thrives doing that, not only does that, but also was the first practice in the state to have bidirectional exchange with the immunization registry. I had to meet her, and I did. And I got to meet both her and Greg when I visited their practice, and we did feature them as a shining example of what can be done, because we're all hearing, and we've heard today, it's all about consolidation and employment. And Dr. Kressly just said, over her dead body. But having been employed and been independent, we'll see. But they are going to show us the path and the torture that they went through and are going through in their endeavor to become connected. And thank you.
So to keep both sides of the room engaged, I'm going to be over here and Sue's going to be at the podium because we have a little demonstration. I have to say I've nearly lost the will to live after Paul's uplifting discussion, but I'm trying to find the silver lining in the cloud, and I think it's that it will convince Sue to take earlier retirement and we can move to Jamaica sooner than previously expected. So anyway, this is about where the rubber meets the road. I was really impressed with Tracy's discussion about what's happening in Pittsburgh, and I can only wish that that was happening on our side of the state more too. But this discussion is about what happens for the people out in the field that have to connect all this stuff and what some of the experience has been and what we'd like it to be. So I'm going to let Sue direct that, and I'm going to be running a little demonstration from over here.
So I want to start by saying that I think in the state of Pennsylvania we already do have an HIE, and it's been prototyped and working and terrific, and we should learn from what we learned with the HIE that we have, and that would be the State Immunization Registry. 4 years ago, I was asked to speak in DC on how to get physicians to increase their adoption and use of immunization registries, because we all see the power of the information exchange in immunization data, and it gives it at the point of care where clinical decision-making happens. And there were a lot of speakers, and New York, our neighbors, decided that they would make it a legal mandate for physicians to report to their state immunization registry. Other states were looking at, could we incent doctors $10 a patient to web enter data into their interface? And my answer was, if you build it right, we will come. So this is my Field of Dreams speech, and I gave the Field of Dreams speech 4 years ago about the IIS. And Greg and I are going to actually demonstrate how many people in the audience have actually seen real-time, bidirectional exchange of data of immunization registry data. A couple of you. We are all going to get to see it. So the answer to this question when we were asked about how we could increase physicians' use of data was that I said it has to have no work or little work for the physician side, the practice side. Has to have a trusted connection, has to be cost little or cost nothing, and we have to get a return on our investment. So if we're sending you information, we want information back. And in the beginning, I will tell you that we were the pilot vendor, and Frank Caniglia I don't think is here today, but it helps to have a big mouth and ask a lot of difficult questions, because I got Frank and Greg in a room and said, you guys build this. Because if you do it the right way and the exchange of information happens the way that the point of care we would use it, people will just go and adopt it. And so what you're going to see is a demonstration of a couple of clinical interfaces with the registry. And now we lost our connection, so we're going to go there. So. Aha. His sight. So one of the things that we knew when people were hand entering data onto the web interface, which a lot of this was built on a web interface, and that's still actually how it's built, but without as many hands entering it. When you have hand entering of data, we all know data decays 8, 10%. When you look at lot numbers, anyone seen lot numbers for vaccines? How many of them you think are actually right when someone web enters them into a field? Maybe half. And so the right answer was to try and get that information to the immunization registry without it touching anybody's hands. So one of the things that happens in my office is when my nurses give a vaccine in my office and it gets on the patient's chart within my electronic health record, I like to say there's a little monkey in the closet that's collecting all the data. It's actually a little service that any information that, any immunization that's given that's there, my nurses have to do nothing except do what they do to administer the record or the immunization. And then once an hour, the little monkey in the back of my closet and my server sends information to Harrisburg. And so we, on a flu clinic one day in my office for 5 hours, gave a couple hundred vaccines. They were being populated in the immunization registry in Harrisburg hour by hour, and there was a lot of information populated very quickly. So initially, a lot of the web-entered data that was happening to immunization registries was going one way, and physicians could go log in on the web and see what immunizations their patients had had at health clinics or health fairs or their prior doctor, but that depended on two things, one of which is that the other people in the community who were giving immunization cared enough to enter that data, which if you look at the statistics in the Pennsylvania State Immunization Registry 5 years ago, and there was a map at the CDC of innovators and great people who had a lot of data in their immunization registry, Pennsylvania was a little embarrassing, and which is one of the reasons I was asked to speak at this conference, and I kept telling them that if you build it, you're automatically going to have a lot of data. I will tell you that when I first started this 2 years ago, Greg, have we been live with the bidirectional? 3? 3 years we've been live with a bidirectional interface. It used to be that maybe 10% of the time I could get some information back about immunizations, usually the birth dose of hepatitis B. Probably 60 to 70% of the time now, I get an almost complete immunization record if I query the registry for information. In 3 years, that's how much difference it's made. Part of that's meaningful use, and people got on the bus, and part of it is because we built it right. And the other part of that is that we've got some big health systems like the Children's Hospital of Philadelphia who now have all their population information in there as well. So this is a patient, and that would be our immunization forecast in my office as I'd see it, with a forecast of what's due. If this was, I'm trying to sync with the registry. In real data, there's a little button here that says sync with the registry. And this is going out and sending information in real time to Harrisburg, and that's how fast I got that information back. So you're going to notice a couple of things. And this is the user interface. Who was talking about user interfaces here? Physicians care about this. Make it easy for me to see where my data matches the registry, where I have data that the registry doesn't, and where the registry data has data that I don't. And so in here, white means we agree on the data. Yellow means that it's in the registry, not in the chart. And if there was anything blue, it would be in my chart, but not in the registry. And then I get a chance as a physician to review that and sanity check it, because now that we're going to start exchanging data, somebody, I believe, on the physician-clinician end needs to sanity check before you just import that into your system, or we're going to have a lot of whisper down the lane, bad data that gets transferred, and I want to sanity check it. And then all I have to do is check the box and import it into my system, and it's imported and I'm updated. That's how quick it is. Now I'm going to challenge you all, let's make all the HIE on steroids do the same thing. If we build it that way, physicians will say, of course this helps how I give point of care decision making to my patients in my office. So similarly, we're going to pick a patient that's new to my office. This happens all the time. Parents say, oh, I have my immunization card at home, or the doctor, I asked for records and didn't give it to me yet. And we all know, especially from a public health standpoint, if I'm going to, I should make every opportunity to vaccinate patients when I have them in front of me. So if I wait till I get immunization information tomorrow, I have lost the opportunity to vaccinate that patient. So this is querying the state registry for a new patient to my office. And this is the bane of a lot of registries' existence. How do you match patient data? We all know the National Patient Identifier, which I dream about. is probably never going to happen. And so in the middle, how do we get rid of duplicate data? Well, we're allowed to sanity check this, and we have some information, and we can pick that out. And so Greg's going to find which is the right patient and match them up. And we're going to query the immunization registry. That's everything that Harrisburg knows that I don't know anything about. And again, I can decide that I'm selecting all of them and going to import them. And now that data, including lot numbers, where it was given, all that information is in my chart, point of care. I make a clinical decision. It was no cost to me, very fast. I got to review it. This is the field of dreams. And if we build the HIE the same way with the same principles, I think it makes a huge difference.
I don't know if you did this on purpose, but look at the red.
No, I didn't do that by purpose, but this is very interesting. Because we have a pediatric-specific EHR and I care about minimal intervals between vaccines, when you do things on paper, it is impossible to remember. Who knows and can recite the whole CDC ACIP language of minimal intervals between all combination vaccines? I think Greg can do it because he helps to program it. But it is incredibly complex. And when you take vaccines that were given without that help of the aided computer logic, people end up giving vaccines out of the intended sequence. And you saw a couple of patients showed up. This was before a minimal interval was given. The hepatitis was given too early. So that's the kind of stuff that when you have embedded clinical decision logic at the point of care, you can make better decisions and you can improve care. Okay. So I don't know who I have to get in a room to sit and program the HIE to work this way, but I'm willing to take volunteers and feed you as much coffee as you need to do it. So that's my field of dreams. Greg's now going to talk about the existing field of weeds that we've been living in trying to create an HIE with our community health network.
So a couple of years ago, the local hospital wanted to pilot a program to connect somebody who was not already in the hospital community and see how that would work. Because if you think about what was said earlier about stage 2 of meaningful use, one of the requirements is you can't just talk to yourself. You have to prove you can talk to other people. And so most of the physician practices that were affiliated with the hospital used the same software, and so it was easy to kind of see how that worked. They decided they wanted to have a third party to see how that would work out. And we ran into a number of obstacles. So this is where the rubber really meets the road in terms of things that don't always work the way you would hope or the way they should. It was a very long implementation cycle. A lot of that was because there was limited support for standards, and indeed there were fewer standards well defined at the time the project got started. And what we found now is that even as we're using it, there's somewhat poor usability of the information that Dr. Kressly's practice is providing to them. And there's also some cost issues which are going to have something to do with sustainability in terms of physicians really staying in the network. So implementation delays. So this is phase 1, and it was relatively small phase, or at least it was intended to be. The first was simply getting lab results out of the hospital. So at Kressly Pediatrics, they've been connected to Quest for a couple of years in terms of results coming back from Quest labs so that they could pull that right onto the chart. And we get this question as a vendor from almost every new practice we take on: why can't I connect to my local hospital? Where it turns out there's about 100 different answers to that question, but they're all fundamentally the same. The existing lab system in the hospital had never been responsible for reporting results electronically outside of the hospital. There was no system in place already to do that. Everything just happened within their Meditech system, and that was that. They did have a system set up where they would automatically fax results to a fax number that was given. But this had to be electronic, so they had to engage a vendor to do HL7 conversion for them. That took quite a while. Then they had to get a connection between the work that the HL7 vendor did and get it into the HIE, and both of those things took longer than anticipated and went through several rounds of testing when the results weren't coming out clean the first time around. The second thing they really wanted, and this was the key to what they wanted from primary care, was outbound patient summaries. So the goal was that anytime somebody came into the office and was seen and something fundamental about their chart changed over the course of the day, they wanted a copy of it. So this is a repository. This community health network is a repository. And the idea is it's keeping a copy of that data. And then theoretically, if patient comes and is seen at the hospital, particularly on an unsolicited basis, like an ER visit, somebody can look that up. They don't have to go back to the original clinician to get the data. So that's how it was implemented, that on a daily basis at the end of the day, you look at all charts that had new finalized encounters or new information, send that batch up to the hospital near the end of the day. They also wanted to support inbound patient summaries, but since Kressly Pediatrics is a PCP, there's really nothing interesting about those encounters coming the other way because they've not yet integrated the referral process. So we passed on doing that level of integration for the first step. So you've heard this in previous presentations today. Everything about health information exchange comes down to two factors: transport and content. And we had problems on both sides. So the HIE vendor had a very high sensitivity to who was connecting to their network, how were they connecting to the network, what were all the security issues, certificate issues, things like that. And they basically said, we're not going to teach you how to connect to our network. We're just going to give you an agent that we have to install on your computer, and we'll take care of the downloading, and we'll make drop boxes with all the information, and we'll monitor when things need to come and go from the system. Well, this was relatively new. Not surprisingly, that service had some flaws in its first few iterations. At one time, it brought our server to a complete stop because it was monopolizing every resource on the machine. So they had to go through a couple iterations to get that working properly, and that was a few extra months right there. Plus, and this is a real problem if it weren't for the fact that Sue maintains her own monkeys back in the closet, as she said earlier. If this had been more of a cloud-based system, imagine the complications of letting them get onto a computer somewhere on the cloud to form that connectivity. At least I could authorize and observe their work when they install that agent, but I don't think that's always practical. Then there's the content side. We heard a lot today about CCD. Stage 2 anoints it as the only remaining standard. Stage 1 had a problem. It was trying to be all things to all people. It wanted to make it, the whole initial Stage 1 be more inclusive. At the time, CCHIT, which had been certifying EHR vendors, 1 year CCR was what we had to certify with, the next year it was CCD. Different vendors were in different stages, and so they anointed both as a possible standard. But really, CCD is the one that's surviving, and so that was kind of how we had gone. Well, it turns out this particular vendor had no support for CCD. They had to get the records as CCRs. So that delayed the project because we couldn't agree on the content, and they were unwilling to do the work on their side to support CCD. Second problem with that was they had no way to filter the document. We had this like really great CCD writer that gave you the whole chart. It was just awesome. It presented everything the doctor knew about the patient. It just overwhelmed the system we were sending it to because they had no way to filter out the stuff they didn't want to see. And so they actually asked us to change what we were sending them so that we actually dumbed down the content so it only included the sections that they wanted to receive. And that took a little while. Then there's the costs. Had the hospital not been subsidizing this as a demonstration project, they would normally charge $15,000 for a connection to the HIE. It's really hard to imagine physician groups feeling that there's any sort of value associated with that amount of money. And even now, as an ongoing fee, and we've paid this fee for this year, it's $59 a month. What are we getting for our $59? Not much. Because the truth is, Sue doesn't send a lot of people to the hospital for their labs. They usually go to Quest and LabCorp because that's where they're capitated. So for the couple of labs a day that get sent to the hospital, we are getting electronic results back now. So that's good because those don't have to be scanned in. The results are available as atomic data so that she can compare it over time. But the outbound results, we have this opportunity now to provide these CCDs. Well, the problem is no one can read them. And so that really becomes the next stage, is the poor usability of what we're sending, and we're going to give you a couple examples in a second. Now, phase 2 of this project is supposed to provide the ability to track the referral process. So Sue theoretically could send a referral through the system as long as it's somebody else who's also affiliated with the hospital who's in that referral pattern, and then again, get a retrieval of the report so it doesn't have to be sent back through fax or on paper. But that phase has not yet been started, and it's impossible really to give a date on when that's going to occur. So poor usability. As I said, initially we had to do our own filtering, so we're really only giving the big 4 that meaningful use requires, which is problem list, allergies, medication list, and labs, which, by the way, are not the most 4 interesting sections if you're a pediatrician. Labs are not that interesting to a pediatrician. Vaccines, vital, not part of the specification, so they don't want them. They have a style sheet. So the way you normally do this, in fact, it's a requirement for those of us who are certified EHRs, is that you have to show that if you receive a CCR or a CCD, you can present it in some comprehensible fashion to the provider as an intact report. So you don't necessarily have to bring it into the system and make lots of little medical records, but you have to at least show them something that you can read to understand what the other doctor is sending you. Well, it turns out their transform is really poorly written. It wasn't pulling all the right fields. Some of the dates are illegibly formatted. And in general, it actually muddies discussion rather than clarifying it. So we came up with a couple of examples. They've been tweaking it. It's still not usable more than a year and a half after we started reporting the tweaks. And here's a couple of examples. Problem list. So if I were to go back to the system that we were just looking at, if Sue was looking at a patient's problems, this is how she would see them, right? So it just kind of says what part of their history it involves, what's the problem, how is it coded. She gets to prioritize it. She gets to say when it started, that sort of thing. All right, if we write our own CCR and then read it back into our own system, so now we're just transforming the electronic copy into the presentation that we would use within our own software if we received a report from any other doctor, it would look sort of like this. A little bit of detail has been lost, but at least you know, their problems. You've still got onset dates. You still have the coding in the description. You know which doctor, most importantly, reported the problem. When the ER physician pulls the same CCR up in the hospital, it looks like this. It is really nice, isn't it? And this is the better of the two examples, and we're about to show you. All you've really got is a code that just says what it is with the ICD-9 way at the end. And notice that all the authors are just office practicum. It's not picking up the doctor that's listed on the individual problem. It's only picking up the master author of the entire document. So there's a complete mismapping of a field there. You don't actually know which doctor to contact to ask more details about that problem. It only gets worse with meds, which is really what you'd think people would most want to know after problems if they're about to deal with a patient who they haven't met before. So again, within our software, this is what it would look like. This is how Sue would see it. You can see it's pretty nicely formatted, all their prescriptions with the patient details. In many cases, why was the prescription written? What condition was it for? Again, who was the patient or who was the doctor who wrote the prescription, so you know who put them on the medication. And then to go through the same set of steps, if we feed that back, if we generate this CCR that they wanted, read it back into our own system just as a raw document and present it as we would any other clinician's report, it would come up like this. Again, a few details lost, but the SIG is still here, the medication name is there, when was it written, the fact that it's an active medication, form strength, whether there's refills, and again, which doctor wrote the script. Now, I want you all to close your eyes for a second because this is really traumatic. This is what they see in the ER. I defy any of you who are not programmers to read that date. And that's all there is. The name of a medication, a date that you can't read. There's this kind of 1Q day in here, but that's just kind of random pieces of the thing. Really no clue what the 0 and the 30 mean, because you'll notice there are no headers or anything that describe what the sequencing of the fields are even. It will not surprise you to learn that the physicians in the hospital do not use the records that Sue is dutifully sending them every night.
Okay, my turn. So that's the field of weeds. Now let's talk about how we make the Taj Mahal. And so there are lessons learned, and in deference to my hospital who worked with me, we are on the leading edge of this. A lot of the standards had not been utilized. We've been doing this for a couple of years. The guys in Pittsburgh who are building this sort of started with a better platform and are working with a lot of existing EHRs. This is getting an independent EHR, independent practice, not within the health system, trying to integrate it and get useful information exchange. And that's where the power of the exchange of data is going to matter, because patients show up at random places for random care at random times with random physicians and clinicians, and we need to have useful data at the point of care, the right information in front of the right person at the right time to make the right clinical decision. So what is the ultimate HIE in my view? It's got patient data exchange, it's got connectivity to registries, biosurveillance. Meaningful Use now talks about biosurveillance. Every independent physician group in in their own EHR, in their own silo, is not going to have the capability of doing all the biosurveillance data that the ONC is talking about. Let's leverage the power of an HIE who can build it once. We can tap in and help to do that. Cancer registries. That's a big issue for those people in adult medicine. If we can use an HIE to collectively transport information, that reduces a burden that a lot of adult providers have in trying to coordinate care for their cancer patients. Chronic disease registries. I mean, and show of hands of people in the room who were involved in the governor's chronic care initiative. Wouldn't it be awesome if somebody just funneled all your data there and you didn't have to do it all by hand? Submitting meaningful use in HEDIS quality programs. If we can leverage the HIE to do this for us, this is the power when physicians will say, sign me up, get me my EHR, sign me up to my HIE. I don't have to do my own meaningful use or HEDIS qualities for Aetna or IBC or whoever your payers are. You guys take the data and figure out where it needs to go. I would argue this is a great place to support clinical trials and research. If we're going to have this information and this power, let's find ways to harness it and identify. I'm a practice with 2 physicians. I have a couple of patients with unusual conditions, 22q11. I don't have enough sample data to do a lot of meaningful information. Those patients are scattered all over the place. Let's find a way to harness the information and support research. There has to be secure physician-to-physician educational exchange so that I can, now if I wanted to ask a friend of mine who's a pediatric endocrinologist about some obscure test or whatever, I could call them, leave them a message, they'll call me back, I'll be with the patient, my staff will leave a message, and we'll spend a day doing telephone tag. A lot of us who are electronically, at least we live on email. Who doesn't live on email? So a lot of physicians are very comfortable sending each other non-patient directed information. I have the 7-year-old patient with X, Y, and Z. What do you think I should do? There is a lot of patient education that happens that is cost effective to the care of the population because I don't have to send that patient to the endocrinologist. I can tap their brain, have a curbside consult, as we say, and that exchange of information. It would be really awesome if I could send that same endocrinologist information with the patient's growth chart so that they would have, or their lab data or something else so that they could help give me a curbside consult and say, you can handle this, you don't need to see this patient, I think you're fine. And then there's exchange patient information with other stakeholders. I am so tired, and because this is the time of year this happens, if I see another kindergarten registration, 6th grade or 11th grade school form, why am I filling out this information when it's in my EHR? Why can't, and we all know there's FERPA and other political problems with this, but we have the data, we have the information. Let's find a way for the schools to tap into that. Let's get the schools in the immunization registry. If they have really good data, why are they coming back to us for it? Let them tap the immunization registry, and somebody can write a population statistics. If there's a pertussis outbreak in, Central Bucks South High School, let's find out the kids who are not immunized, group them, and talk about population health management and making a difference in care that's there. Early intervention, foster care. Foster care is the red-headed stepchild of all of this, and it is where a lot of children get lost in the healthcare system. If there was a way that we could tap into exchanging data in those children who move from provider to emergency room to health clinic, that would be fabulous. And now I'm stuck because you have to memorize all of these things, which are going to make the HIE work. Am I supposed to go here? Chris, I'm stuck. And she's stuck too.
You know why? Because she popped the screen up and that's not the active program.
Oh, because it's not the active program. See, that's the Windows problem. The people who were in Pittsburgh, I think it's fabulous that the physicians are going to be able to see information, but I will argue that that should be the first part, because if you've ever tried to take something on your screen and then transfer that information into your own EHR, You can't do both at the same things unless you have a double-headed monitor, because it's which window is highlighted if you're trying to actually take that information over. So patient data exchange should help with coordination of care, connect to the immunization information system, laboratory information, use my HIE to make this bidirectional. Lab ordering is torture in the electronic world because LabCorp calls a CBC something different, and some of that helps with low ink, but there are definitely differences and subtleties. It's hard for EHR vendors to write to everybody else's standards. Let the HIE be the transitional service of that information. And then patient access. And the question is, where is the right point of patient access? I don't know that I know the answer to that question, but we certainly have to think about it. So remember, when you're coordinating care, there's solicited care, okay? I send my patient and a summary of care record to the allergist. That's easy. But then then we want the specialist. I'd like them to return their findings and their recommendations as an encounter summary. Now, what I would argue is, I would like to be able to get that back in, review it, and decide which pieces of it I want to populate in my EMR so it's more up to date, much like we did when we synced with the immunization registry. But there are unsolicited care. Patients show up in the emergency room and patients who self-refer. And notice I didn't just say emergency room. Urgent care is a big problem. Who's writing this HIE? We got to keep this on our radar. People go to urgent care and retail-based clinics, and somehow we have to remember to capture that information into the system as well. So how do we maximize physician utilization? Okay, it's got to be automated. Don't make it mandatory on my end of a bad, busy day that I need to sync something. Who's ringing? Is it your phone?
The caller there?
Jetsons? It's your scan data. Nope, it's not. Anyway, so okay. We have a problem. Some of the care is solicited, and then the patients who self-refer. I don't know about anybody else, but I have a lot of patients who decide that they need to see the dermatologist for their acne, and we want to make sure that that happens. Okay, now we're losing. Was somebody calling in there? Yeah, it's just detached. Yep. And then let me go back. That's what we're having problem. Okay. Sorry about this. So when we're talking about unsolicited care, when you talk about whether an information system or an HIE keeps data or exchanges data, one of the things that you have to remember in some of the simplistic models of looking at the non-housing of data, you don't want to depend on a physician on the other end. If my patient shows up at 2 o'clock in the morning at the emergency room, I don't want my hospital to send me an electronic query saying, patient X is here, could you give me a summary of care data back? Because I'm not going to see that till 10 o'clock in the morning, and even if I was in the office, I would be angry that I have to prepare it. Somehow, that data exchange has to happen, whether it's housed somewhere or there's computer-to-computer exchange of information without my physical input. We need to, as we talked, automate and passively transfer data, minimize additional cost burdens. I can tell you that if they had made me pay $15,000 for that interface, I would have said, forget it. I'm not piloting this. And I'm the sort of bleeding edge of trying to push technology. My reticent adoptive friends are clearly not going to see the value. You got to harmonize state, regional, and local exchanges. You know, the people who sit in Pittsburgh in the middle of two competing health systems, unless there's a way that that can be harmonized, that's a huge problem and a barrier to adopting. Capability to review external data prior to importing. As we saw on that screen with the IS, I want to look at it, sanity check it, because there may be things that I think that I have more better information than the emergency room who saw the child with the grandmother at 2 in the morning, and I really have a more complete information. I want the ability to sanity check that before I do it. There has to be a way, and this is not well thought out in a lot of existing EHR platforms, to maintain a data pedigree that I can see. If I'm going to import information from the specialist and say, this child was put on this medication, I want to know who put it on it and where I imported that data from, and I want to be able to see it very visibly. There's got to be a way that my partner looks at data in here and says, oh, Sue prescribed that medicine versus Sue imported that medicine from Dr. X, the allergist. Whether it is different font, different color, an easy way with a pedigree, but maintaining a pedigree that's visual to the user so that you can help with clinical decision make, in my view, is key to exchanging and integrating information. There has to be, this is a big issue, confidentiality, analysis, and privacy. Sorry, I live in this world, guys. Saying that 13 and up, we just lose their data is not good enough. We have to go back and look at this and figure out how you do it. Good systems maintain adolescent privacy, but they do it in different ways. I would argue that ONC needs to go back and write us a spec for that. But somehow we have to be thinking about it. I know it's not going to happen first iteration, but let's not let it get lost. And then standardization for efficient patient consent. People, especially who may end up in a couple of HIEs, you can't ask my front staff who has a hard enough time getting today's insurance card, are you opt-in, are you opt-out, did you sign this form, do I have to sign the form, do I have to get you, this has to be thought of in a bigger, broader aspect. And again, for Pennsylvania, I think opt-out is the way to go. Let everybody opt in. Somehow give us the tools, those of you who are building the HIE, here's how you're going to engage your patients. Here, we've made it easy for you to give the appropriate information to your patients so they know what's happening to your data, and you don't have the burden of the receptionist standing there and talking to them for 10 minutes explaining to them why this matters. And then there's the establishment of trust relationship, which we talked about. You can't build this point to point like we did at our hospital system for every single iteration of an HIE. Your turn.
So I guess the question is this going to get better or can it get better? I think it can, and it comes down to standards and interoperability, and I'll go through this quickly because we've seen this in some earlier presentations, but really it's been the lack of standards, it's been the lack of interoperability that's been the bottleneck up until this point. Again, it's about transport and content, and in stage 2 of meaningful use, these issues are addressed in really useful ways for people in the vendor community to finally get everybody on the same bus speaking the same language. So I mentioned earlier in a question I asked somebody else, the ONC has stated as their national goal that information securely follows patients wherever and whenever they seek care. That needs to be the ultimate outcome of any kind of system of this nature that is set up. So we've seen this earlier, the transport standards, right now there's a lot of choices. Some put more of a burden on the EHRs than others. We've heard some discussions today about EHRs that need to stop, and I guess even in Western Pennsylvania, there's the whole question of having to go back to some vendors and talk about how they're going to get connected at all. In stage 2, there's just a couple of very specific things related to the kind of services that you can use to connect to each other, and that'll be a good thing for the entire community. On the content side, as I mentioned, there's way too many standards today. Even in HL7, there's a couple different versions of HL7 that are anointed. In stage 2, it's going to be 2.5 only, and it's going to be a CCD-CDA document only. So as long as everybody's just speaking those two variants, I think that's going to make a huge difference. Also, there's other things the ONC is working on right now that are going to make all of our jobs easier. One is this whole issue of consent and what are the policies. I heard all the work you had to go through in Western Pennsylvania to kind of come up with these things. ONC is trying to urge adoption of policies for trusted information exchanges that are centralized. They're trying to reduce the need to have a one-on-one negotiation every time you're going to exchange data between organizations. They're going to try to provide government as a service, as they're calling it, where they're doing the directory services and the certificate management and discovery. all the different governance standards that involve this exchange so that this doesn't have to always devolve to the individual HIEs that have to reinvent those same wheels. And they are talking about, as long as Paul's not right, that there will be some jump starting of state HIE programs which will help these things get off to a better start. So we were giving out prizes at our user conference this weekend, and I'm sorry to say we didn't bring an extra bag along. Can anybody tell me what this is a photo of? Give you a hint, it's here in Pennsylvania.
Martin got it.
Where exactly? This is now a built part of the turnpike. Do you recognize it? Close? This is Mid-County, that's correct. This is Mid-County at the time that it was under construction, where the northeast extension and the central turnpike come together. Yeah, this is the new Pennsylvania Turnpike that we're talking about building here, and the question is who's going to build it. I think it's the people in this room. It's a really salient topic everywhere. Interestingly enough, and this is not part of our presentation, since we've been sitting here, since I've got my iPad with me, you know, this is what I do for my company. My job is to be responsible for this kind of stuff. Just this morning, I've had 2 email messages about HIEs. One of which is, we have this thing, there's somebody who wants to close in Colorado, but the only way that they can do it is their hospital insists that everybody has to be connected to the HIE or you can't buy the software in the first place unless you have a commitment to the HIE. We are hearing this as a vendor over and over again. HIEs and your willingness to connect to them is now one of those barriers to entry for the vendors. So that's good news. It's good news for the HIE community that the pressure is being brought to bear to really take this seriously and not treat it as, you know, the last item at the bottom of page 10 of the RFP where you can kind of forget about it or assume they'll never get to it. The other more interesting thing in terms of standards, and I think you'll like a couple different things about this. Hello all, this is from my implementation manager. Below are the latest requirements for the NYU HIE interface. So this is for the city of New York. As I see it, we have 2 challenges. The first is operational. Can we meet their outbound requirements? And if so, how soon can we have them in place? Other vendors are facing a similar challenge with the HIE now. And I expect that by Q4 this year, there will be significant competition for Axolotl's resources. How many of you know who Axolotl is? One of the major competing vendors for HIEs. As everyone strives to finish by New York City's 12/31 deadline. Somehow the city of New York has convinced themselves that every doctor in the city of New York will find a way to be connected to the health information exchange before the end of this year. The second is in determining how best to let any of our participating practices who expect to achieve meaningful use certification that this interface will not allow them to fulfill the stage 1 menu set requirement for lab results. Since as explained by, I won't give his name, the inbound feed to doctors will only include text summaries of lab results and not actual atomized data. Et cetera, et cetera, et cetera. And by the way, please contact our practice and have them complete a new VPN agreement since the previous one they've already completed and submitted is no longer accepted by NYU. So throwing another obstacle in the way. And this is in the city of New York, which has actually in many respects been one of the leaders in HIT. It was one of the first bidirectional registries for immunizations, and yet they are still getting their act together. Ultimately, they're not going to do CCD. What we've been told is that they want to, and again, this is useless to primary care physicians. The patient feed from the practice to the HIE is HL7 only. It's demographics, labs, and radiology, which I don't know where they expect primary care doctors to be getting radiology results from to send to them. And they only get back a feed of discharge summaries, and it's all in HL7. So that's like the magic of the initial HIE that's being proposed for the city by the end of the year, and that's what they want doctors to drop everything to do. So we're not the only place that is struggling. I see this all the time. This is by far the openest, dirtiest secret in the industry is nobody's really doing this well. There's a couple of these key beacon sites that are trying their best, and some people are really succeeding, and some of the initial pilots are working better than others. But if you're not where you are, where you'd like to be yet, don't feel bad. Everybody is in that same boat. And to be honest, as a vendor, I don't believe we're going to see significant improvements until we get into 2014 where the standards finally coalesce. So give all of us a good 12 to 18 months to get that under our belts. And I think this conference in 2 years will be telling a remarkably different story about how we're getting to 2020.
But a word of caution, the doctors think you're already there. The doctors really think that the technology has already been established, and why can't I just get all my lab data from 3 surrounding hospitals with a click of a button? They think it's there. So we have a lot of education to do, and my push to them and to you who contact physicians is send them to me, because I think that we need to be at the table having the conversation with you all who are trying to build this, so you have a better understanding of what's important to you, and we can explain to our colleagues what has been built, what hasn't been built, that this is all change that's coming forward, and not all the answers are there, but they can be part of the solution, and help us make the Taj Mahal. Thank you.
So, Greg, do you want to take a question now, or do you want to wait for the panel? Does anybody have a question?
Greg, I have a question about the comment I think you made about standards and how difficult it is to get different groups to agree on standards. Otherwise, you end up with the garbage you showed us on the screen of in the ER in different places where it's ridiculous. I would argue, and I'd like to hear your response to this, that it really isn't about the standards. It's about the value proposition. And that if Susan and I were trading partners, and you were in the middle, and she and I each had figured out a way we could make $1 million if we could just get the technology to work, or $1 million a month, or pick your own number. I don't think we'd care whether it was a version 2.1 or 2.5 or 2.7. We'd say, pick one and just make it work. And there'd be a real sense of urgency driven by us to get beyond the standard issue. So that's a perspective. I'd love to hear your
Well, the
thought
problem
about
is
that.
there's a couple hundred certified EHR products that are all feeding this data back and forth from the hospitals. So they all need to agree on some sort of common language. So that's important. To your value proposition, I would say that if the ER doctors had been shown the possible value of this, they'd be the first ones screaming about the fact that this data is illegible, and it would have been fixed by now. The fact that it's gone for a full year with looking the same despite repeated attempts to get it cleaned up tells me that the value is not being recognized somewhere in that chain. And so that is part of the problem, is you don't have all the doctors engaged around the idea that this exchange is actually useful yet.
Part of the problem is that you don't know what you don't know. And because I live with him, I know what the data should look like and where it should be mapped. Most ER physicians do not have that. The other problem for him as a vendor is there are many of us having this value conversation, and he can't be building it different for 100 different people, because that's that's misuse of limited resources.
Okay, let's give them another round of applause, thanking them for their excellent presentation. And what we're going to do now, Ron, do you want to come forth? And for those of you that are up for the next panel, Ron?